Hello, everybody. I am Annika Reintam-Blaser, working in Lucerne, Switzerland as an intensivist. And our topic today is enteral feeding intolerance, how to define and what to do about. Here are my disclosures. And we start with a very pragmatic definition of enteral feeding intolerance. We can say that any feature of GI dysfunction that result in a reduction in the delivery of enteral feeding, regardless of the underlying cause, is enteral feeding intolerance. This is simple and it can indeed be used at bedside. However, it is subjective, it is not well reproducible, and it is not well usable in the studies. If we look at the evidence, then several different definitions of enteral feeding intolerance have been used. Most of the studies have defined it via large gastric residual volumes, whereas the cutoff have been very different. The second category is GI symptoms combined with large gastric residuals, or GI symptoms without large gastric residuals. And the third category is inadequate enteral nutrition based on either proportional or absolute amount of calories that have been given. If we look at these different components to define enteral feeding intolerance, then all of them have pro and con. GRV is numeric and is rather easily measurable, but it's not even measured in all ICUs. Vomiting does not need any special measurement or assessment. It's easy to notice, except small amounts. And do we really want to see vomiting, which might be associated with risk of aspiration? This remains the question. Diarrhea is non-specific actually, and it is difficult to quantify severity. And we need to discuss, and we come back to this, whether and how it is a sign of enteral feeding intolerance. Or combination of GI symptoms. This allows, of course, more complex assessment of different aspects and parts, but is also subjective and requires clear guidance and time for assessment. Intra-abdominal pressure is also an interesting variable here, and it's a numerical value. It's an advantage of it. And indeed, if intra-abdominal pressure is increasing with enteral nutrition, then we might think that intraluminal pressure was increased. However, we don't know exactly how intra-abdominal pressure reflects GI function. Or then amount of calories administered by enteral nutrition. It's possible to easily identify enteral feeding intolerance like this, putting a clearly defined cutoff. However, it's rather a consequence of enteral feeding intolerance as the syndrome itself depends on feeding practices, does not differentiate etiology, and thereby also is useless for management decisions. There are many pathophysiological mechanisms for enteral feeding intolerance. GI motility disorders, either hypomotility or also hypermotility can be the case. Then malabsorption, even more difficult to detect, and microbiome, where we are not sure yet which role it plays. Enteral feeding intolerance in different parts of GI tract. Gastric, as commonly addressed, is easy to diagnose rather. Management is also rather straightforward. It's usually not severe except aspiration and gastric overdistension. However, if we go further down to the GI tract and look at the small bowel, then it is very difficult to detect enteral feeding intolerance in small bowel or dysmotility in small bowel. And for management, there is no sufficient evidence, and it can possibly lead to several severe consequences. Large bowel, it's easier to detect if diarrhea occurs, more difficult if it's a large bowel distension. It's difficult to achieve regular stool passage without diarrhea. Either we have constipation or obstipation or no passage, or we have diarrhea. To have a regular stool is very difficult. And diarrhea, or mainly also bowel distension, can lead to severe consequences. Future definition is absolutely needed, but it necessitates a consensus process, and it should consider the following steps. First, we apply enteral nutrition, then we monitor GI function after applying enteral nutrition, then we stop or reduce enteral nutrition due to these symptoms that we detected or any other markers, and then we hopefully or possibly also differentiate between different pathophysiological mechanisms behind enteral feeding intolerance. And this would allow us choosing a correct management approach. Why at all might enteral feeding intolerance be harmful? If we think that enteral feeding intolerance is a maladaptive response that affects outcomes, then it can be directly via gastrointestinal dysmotility that leads to changes in microbiome, and these pathogenic organisms will show systemic effects via translocation. And also, dysmotility can lead to regurgitation and aspiration, leading to adverse outcome. And then it can be also indirect effect via inadequate nutritional intake due to feeding intolerance. Because we know that enteral nutrition may improve gastrointestinal motility, it can improve enterocyte function, maybe also mucosal integrity. But we can also look at the enteral feeding intolerance as an adaptive response that is appropriate and proportionate to the severe illness, and it is evolved to attenuate nutrient intake. Maybe to preserve autophagy, which is a cellular pathway that helps us to recycle cytoplasmic material in a controlled way. And any provision of nutrient suppresses the autophagy pathway. So maybe it is good not to get too much food in a severe condition. And also maybe to avoid increased metabolic demand during relative hypoperfusion, because it has been shown that there is a risk of mesenteric ischemia giving full enteral nutrition in a shock state. There are management approaches that could be completely different depending on whether enteral feeding intolerance is considered to be maladaptation or adaptive mechanism. If it's a maladaptation, then we should be rather aggressive and interventional and treat enteral feeding intolerance to achieve success of enteral nutrition to improve outcomes. On the other hand, if we think that it is adaptation, then we should be rather conservative and observing, and we should rather reduce enteral nutrition than initiate treatment if enteral feeding intolerance occurs. However, we know from intensive care that any adaptive responses like tachypnea or tachycardia, if they are left untreated or uncontrolled for extended periods, they start causing harm. And then probably enteral feeding intolerance might also be in the beginning adaptive, but become maladaptive due to longer persistence. So possibly enteral feeding intolerance may be observed and left untreated for short periods, but should be treated when persisting and leading to further complications. We come back to this still. If we look at the treatment of enteral feeding intolerance and effect of this treatment on outcome, then we know that enteral feeding intolerance is associated with adverse outcome, but causality between feeding intolerance and outcome is unclear. And there is no robust evidence that any treatment of enteral feeding intolerance with prokinetics mainly prokinetics used, improves patient-centered outcomes. There is evidence that post-pyloric feeding probably reduces pneumonia, but whether this is due to treating enteral feeding intolerance is unclear. In one earlier study, we tested several definitions of enteral feeding intolerance in one patient group and saw that in same patients, applying different definitions of enteral feeding intolerance results in very different prevalence and different mortality. Here the definitions with gastric residual volumes, here definitions with enteral nutrition, amount of calories, and here with GI symptoms. And we can select here several ones marked here that are associated with increased mortality. If we look here at the prevalence, then they show very different prevalence and of course also very different mortality. So we can say that the association of enteral feeding intolerance with outcome currently depends on definition of enteral feeding intolerance. And to identify optimal management strategies and summarize all the evidence, uniform approach would be warranted. Practical approach to detect enteral feeding intolerance at bedside would be starting enteral nutrition slowly. Before, of course, need to check contraindications and assess risk of aspiration mainly. Possible signs of enteral feeding intolerance need to be monitored after starting enteral nutrition. And these are listed here, and we already talked about them. Any GI symptom does not necessitate discontinuation of enteral nutrition. Treatment according to the signs should be considered, but we already said maybe we should observe in the beginning before starting aggressive treatment. And reassessment is needed, including general condition of the patient. And enteral feeding intolerance would then, in a practical way, be defined as worsening of GI function in response to feeding attempt. Now the million-dollar question, how to assess GI dysfunction. We have recently finished an ISOFA study where we were aiming to create a new scoring system for GI dysfunction. It is not yet published. We are in the latest phase of analysis. And in univariate analysis there, we saw that some GI symptoms were associated with 28 and or 90 days mortality. These are absent bowel sounds, GI paralysis, abdominal distension, and GRV were cut off. We identified in this study was 200 ml. We also studied biomarkers, citrulline and intestinal fatty acid binding protein, and they were not associated with mortality. In multivariate analysis, our previous descriptive acute gastrointestinal injury grade was independent predictor of mortality when tested together with SOFA score. So it added to SOFA score. And we can, of course, look at this, or mainly this acute gastrointestinal injury grade has been also developed as a combination of GI symptoms looked at as expression of enteral feeding intolerance. So we have the same way now again. We have no clear reason to withhold enteral nutrition. So we start enteral nutrition slowly. Look whether there is a problem with gastric emptying. If no, then we can increase and reassess. If yes, then we need to stop and restart or keep enteral nutrition at low rate. As a first step, apply prokinetics as a second step, or apply post-pyloric feeding as a third step. However, as we already said before, there can also be bowel distension or diarrhea as excuse me, as signs of enteral feeding intolerance. And importantly, these may occur independently what happened to the emptying of the stomach. And even more importantly, if we have really gastroparesis as a main problem and apply gastroprokinetics, then we solve the problem. We also solve the problem with post-pyloric feeding. However, if the impaired gastric emptying was secondary to small bowel dysmotility, and we apply prokinetics, we get limited effect. But if we apply in post-pyloric feeding in this patient, we get possibly severe consequences. So we should try to assess whether the problem is the stomach or a small bowel. So looking at the risk factors, prophylaxis and management, we see that the risk factors are all the same for hypomotility, either in stomach, small bowel or large bowel. And also prophylaxis is applicable more or less for all, whereas management is different for upper part and lower part regarding prokinetics. If we look at the diarrhea, so hypermotility, then we see that some aspects which were mentioned here, like early enteral nutrition as prophylaxis of hypomotility, here enteral nutrition is mentioned as a risk factor for diarrhea. And also we have here erythromycin being antibiotics, whereas antibiotics is a risk factor for diarrhea. So the management is completely different, and sometimes management of hypomotility can be a risk factor for hypermotility. Here, sites of action of drugs used for enteral feeding intolerance. Here, the upper part, very limited number of drugs, and here for the lower part. Here may be important to mention for large bowel, we got acetylcholine agonists or mainly drugs working on this pathway. Acetylcholine as a main neurotransmitter of parasympathetic nervous system. And we can also ask laxatives versus diarrhea, as already mentioned in a previous slide. We might want to apply laxatives early. We need to know that some of them take quite a lot of time. For example, bisacodyl has effect in 12 hours, whereas rectal form acts immediately. And other laxatives may take even more than 24 hours. And now we need to also consider diarrhea as a sign of feeding intolerance, because some transit time is needed for absorption to be normally performed. And diarrhea may also occur in ICU patients due to postprandial persisting fasting pattern. So regular constructions move the nutrition to the colon fast, and chymus reaching the colon has high osmolality, and this leads to diarrhea. There are also different types of enteral nutrition that may be related or not to diarrhea. Anyway, any enteral nutrition formula is not a normal food. It's liquid, and digestion in stomach is actually not needed. Suppresses gastric and pancreatobiliary secretion. Osmolality is often higher than normal GI secretions, and it lacks complex carbohydrate residues entering the colon as fermentable food for the colonic microbiota. In some non-ICU meta-analysis, fibers added to enteral nutrition showed less diarrhea. And in some studies in non-ICU and ICU, soluble fibers also showed less diarrhea. Whereas a study using hydrolyzed whey protein versus standard showed no difference regards diarrhea. So here are the medications, a short list that can be used or considered for GI motility disorders. Upper part, new drugs recently tested. Unfortunately, no new drug coming in the everyday practice from there. Paralysis of the lower GI tract, laxatives, neostigmine, maybe also pantothenic acid. And if diarrhea persists, then considering pancreatic enzymes or cholestyramine could be, but it needs differential diagnosis. And here, just an example where we were in trouble to solve the small bowel dysfunction or small bowel hypomotility in a patient, and applied gastrografin for diagnosis actually. And you see here distended small bowel filled with gastrografin. And diagnostics showed that we actually managed to resolve the problem that persisted several days before. So it may be effective when you do diagnostics with gastrografin. It may have an effect as prokinetics. Consequences of this motility, there are many, and some of them can be life-threatening. For example, massive aspiration, bowel ischemia or bowel perforation, and also associated with diarrhea, water and electrolyte, mainly potassium changes or shifts, and also hemodynamic instability related to fluid loss. So these consequences should be avoided. And to conclude, enteral feeding intolerance is currently vaguely defined. Only gastric intolerance is commonly addressed. Consensus definition is very much warranted, and other forms next to gastroparesis need to be addressed too. Gastrointestinal tolerance should be tested with starting slow enteral nutrition under monitoring of GI symptoms and probably or possibly also intraabdominal pressure. Protocol-based assessment and management could be helpful. However, the management options are really limited and they have unclear effect on patient-centered outcome. But treating the bowel dysfunction or treating enteral feeding intolerance could help avoiding severe consequences, and this is important and needed. Thank you very much.